Right. I see a good number on, so I think we are good to go ahead and launch. Happy Friday, everyone. Welcome to our Lunch and Learn series. This is our third year of offering a monthly education series that we hope for you is filled with wonderful information and covering really pertinent topics related to oncology care. I'm thrilled today to be joined by Dr. Rahimi and Dr. Sher from our radiation oncology team. Before we get started, I'm going to take a minute to introduce myself, and then we'll get into their introductions and pass it off to them. I'm Alex Huffman. I am the Director of Supportive Care in Clinical in Integrative Oncology at the Cancer Center, and I have had the pleasure of moderating these Lunch and Learn series throughout the time we've been offering them. Just a few housekeeping notes this morning. We are in webinar feature mode, so you guys are muted and you do have the ability to enter your questions in the chat. Many of you submitted questions in advance, and we are going to get to those, especially the ones that the presenters don't answer at the end of the session. I did want to just give you a note that we are not in this session able to provide direct medical advice. So we welcome those questions. We want to get you as much information and make this as relevant as possible to you, but we may not be able to answer specific questions on diagnoses and treatment. So with all of that said, I am thrilled to launch our first webinar in 2025. And that is titled Zap the Cancer and the Fear, What to Expect with Radiotherapy. Dr. Asal Rahimi is a professor in the Department of Radiation Oncology at UT Southwestern and is also the division chief of breast radiation and the associate vice chair of program development. She's also the medical director of the clinical research office in Simmons Cancer Center, which currently has a portfolio of over 500 trials. Her clinical research interests have been in developing stereotactic partial breast irradiation techniques and reducing the volume of radiation and the number of fractions per patients. And we're going to hear from Dr. Rahimi in just a minute, and Dr. Sher is going to kick us off. Dr. Sher is a professor of radiation oncology at UT Southwestern Medical Center, where he's the medical director and vice chair of operations and quality. He also serves as the disease site leader for head and neck radiation oncology and is the director of Precision Radiation Oncology Fellowship. Dr. Sher's academic interest is in the leveraging of technological innovations to improve the therapeutic ratio, most recently focusing on adaptive radiotherapy and artificial intelligence. Dr. Sher, we are thrilled to hand it over to you to begin.
Wonderful. Well, I'll start by just thanking you and the Cancer Center for inviting us to have this conversation. Over the last couple of weeks, as sort of I knew this was happening, was sort of engaging with the patients that I see every day, and it really became clear that there's a lot of questions that are really quite relevant for understanding radiation, and both Dr. Rahimi and I will try to answer as many as we can, both during our presentation and afterwards. So both of us have several disclosures, none of which, frankly, are really related to this educational topic. But at a very high level, we wanted to address kind of some basic aspects of radiation therapy and then a little bit more specifics as to what patients can experience during treatment. So we'll start at a very sort of fundamental level about what is radiation, what is radiotherapy, and sort of what does it even do to you from a biological perspective. Then talk more, and I'll hand it off to Dr. Rahimi at this point, about what is actually involved when someone says, I'm getting radiation, from the beginning, from the time you meet a radiation oncologist to the time you're actually in the treatment room. And then finally, we'll touch on some common side effects from radiation. And I think that this will be kind of a nice launching pad for a lot of the questions that I think the community has. So let's start with what is radiation? Sort of at a very sort of fundamental level, whenever you're trying to treat cancer, whether it's to cure patients or to palliate a symptom, there's three basic treatment types. And I think it's important to start here because at the end of the day, the side effects that you experience from radiation relate to the kind of therapy that it is. So, surgery is a tried and true method of treating cancer. We call that a local therapy. A local therapy is something that really impacts the patient and obviously the cancer by just actively touching, removing, involving the area that has the disease itself. So surgery cuts out tumors. You can cut out the gross tumors that you can see on a scan. You can also do a surgery to take out microscopic cancers, say in lymph nodes. That's a local therapy using manual removal. Radiation therapy, which is what we do, is also a local therapy. So we see a tumor on a scan or a PET scan or a CAT scan or an MRI, and radiation acts directly on it by treating both the gross disease, the cancer that you can see, and often treating areas of the body that have microscopic cancer or may have small volumes of cancer. That's where the radiation works, locally where you aim the beam. And then, of course, you have systemic therapy. And systemic treatments go everywhere. So, chemotherapy is the most common. That can be done intravenously. It can be done orally. Now, there's also immunotherapy. There's hormonal therapies. There's new biological therapies. All of these are exciting treatments, but they treat cancer that's floating around. It's intravenous, and the side effects are related often to the fact that it can go anywhere in the body. And so fundamentally, surgery, radiation, systemic therapy have different kinds of impacts on the patient, in part because of where the therapies are aimed. So this is a typical radiation machine. As a radiation oncologist, I take it for granted, but really, until I went to my radiation oncology rotation, I had no idea what this was. And so I wanted to kind of highlight very briefly what's involved when you go into the room. So these rooms are usually pretty big, actually. They're pretty spacious because these machines themselves are pretty large. And so what I label A, this is actually where the beam comes out. Sort of there's a generator in here, and the beam kind of gets sort of directed here, and then it comes out of this, the head of the machine. So this machine, called the gantry, rotates around the patient kind of like this, 360 degrees, and can go at many different angles. This here, what I labeled B, is the couch. That's the table that patients lay on, and they are almost always on their back, although there are some other positions that Dr. Rahimi will discuss in terms of how to deliver the radiation. And this couch moves in many different directions. It moves in, it moves up, it moves down, and this really allows us to get patients into the ideal position. And C, what I labeled C, is actually a mini CAT scan. It's an imager. It's something that allows us to capture images prior to each treatment. And this is actually relatively new over the past, call it 15 years, but allows us to get really sort of elegant and precise pictures so we know exactly where the beam is being ranged. So when a patient gets treated, typically they're placed on the couch, they're then moved into the treatment position, and that's a whole group of technicians called radiation therapists. And then they leave the room, and then patients are in the room by themselves, but have a lot of different communication options. There's radio between the therapists on the outside. There's cameras, so we can see everything. And the first thing they do is the machine spins around, actually, and it obtains a small CAT scan. It's like a mini CT scan that allows for extremely precise positioning. And so this is one example of a linear accelerator or radiation machine. There's many other kinds and forms, but at the end of the day, they're very similar to this. They involve delivery device, they involve the couch where the patient is laying, and they involve the imager that allows us to be very precise with where the beam is going. So how does radiation work? This is sort of very core to how we employ the treatment. And at the bottom line is that cancer cells are part of us. They grow and they divide, and they grow and divide in really aberrant and abnormal ways. But ultimately, it's very similar to how our normal cells grow. And if we can eradicate the machinery, what's in the cell, the molecular mechanisms that the cells need to grow and divide, the cancer cell dies. And the most important part of that growth process and machinery is DNA, which makes sense, right? I mean, everything ultimately comes from DNA. If we can kill the DNA of a tumor cell, we can kill that cell. And ultimately, that's the mechanism of radiation therapy. And so radiation comes in many different forms, and we'll touch on this a little bit later. But the most common one is called a photon. It's basically extremely high energy light. A different form of a photon is called a gamma ray. It's a bit more sort of common in common parlance is gamma rays, but ultimately it's like very high energy light. And when the radiation interacts with human tissue, it actually generates electrons. Electrons are very high energy, but they're all over the place. Electrons are in the walls. They, power televisions and such. But this radiation is able to very precisely generate electrons right where the tumor is. Those electrons actually then interact with water and oxygen to generate free radicals. Oftentimes we think of free radicals as bad. We try to avoid free radicals with antioxidants and things. But in this case, free radicals are critically important because those radicals which interact with DNA allows us to break the DNA. And here's an example of sort of like a schema of that. So we start with, ionizing radiation from the head of the machine. It then interacts with the tissue and generates free radicals, reactive oxygen species, these sort of very abnormal chemicals, more or less, that interact with DNA, and they break the DNA. And when you break the DNA, there's two strands of DNA. You have to break both really for it to be effective. The cell can't divide. Now, that DNA damage happens, and this is actually relevant to understand the time course because the cell doesn't necessarily die right away. It tries to repair. Now, the more normal a cell is, as in like our normal tissues, the better that cell is at repairing the damage. It's actually very capable. The more distorted the cell, basically cancer, which is growing, out of hand, it's really quite incapable of repairing the damage. So that's one of the benefits, actually, of one of the ways in which radiation really primarily damages the cancer cells because they're not able to repair the damage that is brought by the radiation. Then the cell tries to divide. So you've damaged the DNA, but it's still there, kind of percolating, doing its thing. But at some point, it wants to divide, right, and grow. That growth can happen in a couple hours later, days later. It can even take weeks later before the cell tries to divide. And then when those DNA can't divide as well and it can't double, it causes cell death. And, that's one of the reasons why when we talk about, when do we do another scan? Do we wait? Do we do it right away? Do we wait 3 months? Do we do another PET scan in 6 months? All of this relates because this damage happens weeks to months even after the radiation is completed. So many of the machines look different. You can hear different buzzwords in the common media or commercials and so on. But ultimately, all of the linear accelerators, the machines, deliver the energy this way to cause DNA damage. But it's important to understand that normal tissues are spared during this process by two basic mechanisms. The first is the biology. I mean, our normal cells are able to recover. I mean, we cut ourselves all the time. You have surgical injuries, you break a bone. We can repair. This is part of the way in which we've evolved. And cancer cells can't do that. So we get a relative improvement in repair for normal tissues. And the other piece to this, which is also very important, is that the radiation treatment is extremely precise. It is a different world of radiation than it was even 5 years ago. I've been practicing for about 20 years now as an attending physician. It is almost like science fiction compared to when I started practice as an attending. And we're really able to treat the tumor and just the tumor. So I don't want to get too much into buzzwords or sort of technologies and such, but I think it's important to understand what's actually happening when you're delivering radiation because it's a very common question, like how does it actually work? So radiation is most commonly now delivered in something called IMRT, or intensity modulated radiation therapy. It is probably across sort of most therapies now the most common. And it's really been a revolution to minimize dose to normal tissues. And there's a couple of ways of doing this. One can be, a couple of beams around a patient. Some of them could be an arc where at every degree, 360 degrees, it's delivering a different dose. But inside the machine, there's something called a collimator, a multi-leaf collimator. And the name is not important. What's important is that it allows us to create very small and precise openings to treat the tumor. So in this example, all of this stuff here, these are actually leaves that open and close kind of very fast. You're just treating this little tumor and a little bit of area there. Here, you're just treating this part of the tumor. And so at every point, you're able to block normal tissue so it doesn't get treated and treat different parts of the tumor so that it can get the full dose. Now, what happens is that you have many different angles and they all converge on one spot. So here's an example of a treatment plan where there's a beam here and a beam here and a beam here. And the hotter it is, so the more red it is, that's the dose that's going to kill the tumor, which is right around here. And the cooler it is, the more blue, the lower the dose. And so you can see all around here, there's very low dose actually. But in the middle, it all converges. So that's one of the ways in which we can sort of spare normal tissues is by spreading it out and having it all focus on one area. So one now very common type of radiation is called stereotactic radiation. It's called SBRT or stereotactic ablative radiotherapy. And this is when you deliver a very high dose of radiation just on a very tiny target, a small target over 1 to 5 fractions or doses. This is something that we do pretty commonly, especially here at UT Southwestern, but also nationwide. There's also a kind of radiation called electron beam radiation, which is very superficial. and is treated probably most commonly to treat a skin cancer or often after breast surgery to treat resection cavities. And there's also proton beam radiation, which is ideally used in kids. I'd like to conclude this part of it by talking about something called adaptive radiation. So adaptive radiotherapy is a newer form of radiation, typically using that sort of very conformal treatment called IMRT, where we can change or adapt the treatment fields on the fly like that. We can do basically in 10 minutes, 15 minutes, what it used to take literally a week to do, literally a week. It's quite remarkable. We use an MRI or a CAT scan to define what we're treating in real time, like in the moment. The physician is there, you're in the room, patient's in the room, excuse me, we're in the back, and we're making adjustments as needed. And it can be used to treat almost any side of the body. These are what the machines look like. They're a bit more involved in terms of their architecture inside, their machinery. This is one of them. There's a CAT scanner built in this to treat with adaptive radiation. This one here it's called Unity. It's a machine where there's an MRI in here, so it kind of looks like an MRI, but there's also a treatment machine back there. So there's sort of these very involved units. And, the key, I think, from a patient perspective is that as physicians too, we only want to treat cancer. We don't want to treat normal tissue. And our goal always is to treat as little normal tissue as possible. But the challenge is that people change during treatment. People lose weight, the tumor shrinks, the anatomy is always different on any given day, and you want to be able to adjust for that. Whereas historically, treatment plans are very static. So you do a radiation planning appointment, in January, you're using that same treatment plan in the end of February. It's not realistic to think there's no change. So here, without adaptive, for example, this color is where you're treating. This is someone's head and neck. This is their neck right here. This is their jaw. But with adaptive radiation, we're able to eliminate almost the dose that's going to this part of the back of the throat. So it's a very powerful therapy that I think is going to be, it is the next generation of radiation treatment. So my last slide before I hand it over to Dr. Rahimi is some language. Each radiation dose is called a fraction. And that the fractionation scheme can run the gamut. It can be one dose or one fraction to 42 fractions. We don't do that very much anymore, but that's the language that we use. And the term hypofractionation, which is very important now, means you're giving just a few number of fractions with a bigger dose per fraction. So a lot of times we just may fall into this lingo, number of fractions, fraction scheme, hypofractionation. It just tells you the number of doses you're doing. So with that, I'm going to hand it over to Dr. Rahimi.
Thank you so much for having us. Okay, so I'm going to talk more about how is radiation therapy delivered? So what does the patient expect to kind of go through once they come into the radiation oncology department? So first, obviously, a patient would come to the radiation oncology department and they would have a 1-hour consultation with a radiation oncologist. So that's somebody that has been trained in radiation and has done 5 years of residency after medical school, all on radiation. And then essentially, if the doctor decides that you would be a good candidate for radiation, they would plan you for something called a simulation. And a simulation is basically a session that takes about 30 to 60 minutes in which the patient would come in and get most likely a CT scan, although there can be an MRI or a PET scan involved with that. And then that allows the physician to obtain images of the patient and get immediate information about their anatomy and the anatomy of the tumor. Once we obtain that information, the third part of this is the actual radiation planning. And this requires an entire team that you probably would not get introduced to because they kind of are doing work behind the scenes. But essentially what would happen is the MD would contour out, or DO, the radiation oncologist would contour out all of the organs that we need to protect, like, for example, heart, lungs, ribs, bladder, just kind of depending on where we're treating, we would contour out the tumor. So we would draw out on the CT scan the tumor and all of the areas that we want to try to protect. Then we have a team of dosimetrists, and what their job is to build a radiation plan with our computing system that we have, and they can do that with many different beam arrangements. So we would then evaluate after they come up with a plan together with the doctor, the different plan, and then the doctor would fine tune the plan based off of what they have reviewed. And they would basically be looking at every single dose of every important structure and making sure that that we are in agreement with that dose, and we have a sense of what doses and what structures can tolerate what doses. So we always try to stay within those thresholds so that we can deliver a safe plan. And then after we approve that plan, then there's a physics team. We have special physicists called medical physicists that do special training in everything about radiation. And the physicists will then double check the plan. Another job of the medical physicist is that they are doing quality assurance on our radiation machines on a daily basis. And they're testing our radiation machines to make sure that they are going to deliver the dose exactly as the plan tells us it will. And then they're also checking our plans. So they will perform some quality assurance on the plan and on the radiation machine. So the fourth part, after everybody is in agreement with all of that, would be having the patient start the actual radiation. And then the fifth part is the doctor would be having weekly visits with the patient to monitor any side effects. So the next part of this talk will kind of just go through each one of those little parts in a little bit more detail. Okay, so after the consultation, we'll go with the simulation, and I'm going to show you a picture of a CT simulator. This is what the CT simulator looks like. And so again, the patient would be laying down on this, and they could be laying down in different positions depending on what site we're treating. But we will utilize different immobilization devices used for setup. And basically what an immobilization device is, it's a device that allows us to have the patient be in the same exact position every single day. So as we're treating with radiation, the target is not moving. So you can see on the next slide, depending on what we're treating, there's different immobilization devices. So in the upper left-hand corner, there's, yes, the head and neck treatments, and brain treatments will sometimes employ a mask, and that will help the skull to not move around and the neck to not move around. On the right there, we have a patient laying down, and they are laying on a backlock bag, which is that blue bag. It's kind of like a bean bag. And so we can form it and mold it to surround the patient, so the patient can put their legs in this particular picture in the same exact position every day. And on the bottom left, you can see a better picture of what the backlock bag looks like. So it kind of just helps mold the patient. And then in the last picture on the bottom right, we had to elevate the patient's arm. So we have a backlock bag that, it hardens around the arm so that it can support the arm as the patient has their arm up in that treatment position. Sometimes we'll employ IV contrast. And then we have different frames that we use based off of the different treatments. This is an example of one of our homemade frames that we have in the department. It's a wooden frame, and you can see the backlock bag there. And then on the next slide, we have several more frames. So this is a stereotactic frame. Dr. Sher spoke about SABRE or SBRT. That's when we're doing very kind of more pinpointed treatments. So that requires a special frame and a special backlock bag in the white there. And so basically there is an indexing system, which is the metal on the top, the white plastic and that metal on the top. And then that helps us index the patient's position to the frame so that we can get to sub-millimeter accuracy when the patient is on the table for our stereotactic treatments. So that's a little bit of a different setup. And these frames, there's many different frames. This is an older frame, but there's different manufacturers, and this is an example of one of those frames. Okay, so the position on the radiation machine really matters, because based off of your position, the anatomy is completely different. So from the breast cancer perspective, this is just one example of how, two different positions can make all the difference in this particular patient. So we have a CT scan, and this is a picture of kind of like a bread loaf slice of the CT scan. So you're looking from the feet up, and you can see in panel A, there's the liver, and then the heart. And then in the blue drawing, that's the breast. And the yellow is the beams, and we come in with these tangential beams. But if we were to treat with these tangential beams, you can see that the heart will be irradiated, which is not optimal. And so our job as radiation oncologists is to try to fix that and to try to minimize any dose to the heart, because that's obviously an important structure that we don't want to treat during breast cancer. So for this particular patient, one way to do that is, instead of treating the patient on their back, is treat them on their stomach, and use the same tangential beams. And what happens is the breast kind of falls forward, and we're able to utilize very similar beams, but really minimize the amount of heart that's being irradiated in this treatment position. And so on the next slide, we can see that this is the setup. So this requires a special board in which the patient would be laying on their stomach, and then the breast would hang down. And then that allows us to, kind of immobilize the patient so that we could really minimize the dose to the heart. And that's another picture on the bottom left. And you can see how nicely the heart is outside of the radiation field. So on the next slide, you can see that another way that we can do this is, instead of treating the patient on their stomach, is treating them on their back. This is probably the more common way we do it for breast cancer treatments. In panel A, you see that the heart again is right up against the chest wall and the breast. So coming in with regular tangents in panel C, the heart again would be in the radiation field, not optimal. So another way to mitigate this is have the patient take a big, deep breath, get a lot of air into the lungs, and we can actually move the heart behind, so moving it behind and down. So in panel D, you can see the heart actually moves outside of the radiation beam. And then we treat the patient in the breath hold position. So, these are very important techniques, so we can really optimize the radiation, and we're paying attention to all of these important structures when we're doing the radiation planning and we're doing the simulation to assure that we are minimizing the dose to all these important structures. Okay. So now this is just another plan for a patient that is in the breath hold, and you can see how beautifully the heart is spared with this breath hold technique. Okay, so let's talk a little bit about another kind of technique that we have, which is Gamma Knife. Gamma Knife is a special machine that uses cobalt radiation sources to treat brain tumors. And this machine is very important in that it really can pinpoint tumors, but again, we need to immobilize the head and the skull in order for us to do that. So we have a very excellent program here for Gamma Knife with top-notch technology, the latest machines, which you can see here. And then on the next slide, we have different frames that we can place around the patient's head in order to help us, really immobilize this, because these are treatments that are typically, one dose, sometimes 2 or 3 doses. But because we're doing high dose, we really need to make sure that the head is not going to move during the radiation treatments. And these frames allow us to do that and to deliver those treatments. On the next slide, you can see a tumor, which is in the white, and in the green outline, that's the dose of radiation. And you can see how beautifully and how tight the Gamma Knife allows us to deliver dose to the brain tumor, which comes back to basically immobilizing the patient with that frame. Okay. Okay, so step 3, moving through the treatments, is once the physician and the team basically gets all of the pictures from the CT scan, then we start doing a process called contouring, in which we draw out all of the important structures and we draw out the areas that we want to have the radiation go to. This process is called contouring. It takes time. The more complicated areas like head and neck are going to take even more time. And the more structures there are, then we have to be more careful and be more precise in doing our drawings before we actually do the radiation planning. And so once we do this, then we can do the radiation plan, and then we'll have doses for each one of those structures, and we know exactly how much radiation each one of those structures is going to get, and that helps us define what is a good plan and what is not a good plan, and what is a plan that needs to be tweaked. So once we get the plan, step 4 is delivery of the radiation. So then at that point, we would invite the patient to come back. This is just one machine. We have many different machines, but we would have the patient come back and they would lay down on the couch, which is the radiation machine, and we would have delivery of the radiation. Before we do that, we would have images, usually like X-rays or CT scans, that we would take right before the radiation to assure that we're in the right position. And once the physician has reviewed those, then we would deliver the radiation. And then the way that we can monitor, one way that we can monitor in some subsites that we're treating, the actual radiation delivery during the treatments is a system using surface tracking, which are these red beams here. And these are just laser beams, but these laser beams that are coming from the ceiling are essentially tracking the patient's outline of their body at all times and to the millimeter. So it's extremely accurate, because if, again, things are inaccurate, then the radiation will be inaccurate. So so the outline of the patient, of the surface of the patient, is being monitored. And then on the next screen, we can see that this is kind of what it would look like on the console for the therapist. Obviously, this is not the same patient, but this is a breast patient. And this is a patient that's undergoing deep inspiration breath hold. So we really need to make sure that it's accurate so that the heart is in the right position. And then the therapist, which you would see on the next screen, would be monitoring the patient's position in 6 different motions. So like the vertical, the longitudinal, the lateral, and then pitch, roll, and yaw, which are different degrees of rotation. And so we can set these thresholds. Usually we set it for breast at least for like 3 millimeters. So you can see the beam is off, and those thresholds are outside of tolerance. They're more than 3 millimeters. So we obviously are not going to treat the patient during that time, but then we'll tell the patient to take a big, deep breath. And then we see that now all the thresholds are green within that 3 millimeter threshold. And then that tells our therapist we're safe to treat. And then as they're getting treatment with radiation, they're constantly monitoring this. So if any of those thresholds go outside of whatever predefined threshold we set, then we can turn the beam off and go back and reposition the patient, or give the patient a break, whatever the patient needs, to make sure that we get back to that point where everything is green and everything is, in very accurate for us to deliver the radiation beam. So the patient would get their treatments, and then during the treatments, step 5, weekly, the physician will meet with the patient on a weekly basis to monitor any side effects and to go over any questions they may have. These are quick treatments. I mean, these are quick appointments, but typically 5, 10, 15 minutes, but it gives us time weekly for the patient to meet with their doctor and basically just make sure that everybody feels comfortable and that they're not having too many side effects. And if they are, it gives the doctor time to manage those side effects. So what are those side effects of radiation? So Dr. Sher will now talk about the head and neck and thorax radiation.
All right, thanks so much. All right, so what we'd like to do now in this part is talk about some of the side effects of radiation before then opening it up for a discussion. Having some technical, there we go. All right. So a very important principle in terms of understanding the impact of radiation is that it causes side effects where the beam is aimed. This is actually an extremely important idea as you're thinking or concerned about what radiation therapy can do from a side effect standpoint. So as opposed to systemic treatments, chemotherapies and such, which go around the body, radiation side effects are really limited to the treatment field. So a good example or comparison is hair loss. So whereas chemo, for example, can cause hair loss everywhere because the chemo is going everywhere, radiation would only cause hair loss over the skin that's being irradiated, whether it's in the scalp or somewhere else. And so when you get concerned or worry about where the side effect might be, it really is where the radiation is being aimed. So an important distinction in terms of how we think about radiation side effects or complications is that they can either be categorized as an early or an acute effect versus a chronic or a late effect. And we do we do use these sort of distinctions for a few reasons. I mean, one of them is that most acute side effects develop over the course of treatment, and sometimes they peak, and often they peak after the radiation over by a day, a week sometimes, but then they resolve. And there's a lot that we can do, as I'll show you, to help mitigate that. But those side effects, they come and then they go. Late effects or chronic side effects of radiation can develop months or even years after treatment, and in many respects are what we really aim to avoid with some of our complicated and technologically heavy therapies. So here are some common acute side effects. Fatigue is seen in almost every patient that we treat. You can treat someone's foot, they may still get tired because it releases sort of these local chemicals or hormones that can lead to sort of a systemic feeling of tiredness. Now, that fatigue can be really variable. The more you treat, the more higher number of days, the bigger the volume. All of these sort of parameters affect how tired a patient can get, but fatigue can happen. And it's temporary, and there's some things, particularly like exercise and sort of keeping active, that can help minimize it. Fatigue is a pretty common side effect. When you're treating someone in their head and neck or in their thorax, esophagus or lung, something we call mucositis or esophagitis is pretty common, and that can lead to mouth and throat pain. It can lead to problems swallowing. It can often be some of the more frustrating parts of the radiation treatment. And even if there's not sort of problem swallowing, a lot of times patients will have thick secretions when you're treating in this part of the body. Skin reaction, or called dermatitis, is also very common. So this is also really variable. It can go from a little pink or, just you notice just a little change to something that can be quite a bad sunburn. But the good news is that heals quite quickly. So if you do have a pretty significant skin reaction, it usually heals, almost always heals within 2 or 3 weeks, if not sooner. Another common one, as I mentioned earlier, was hair loss, and it typically grows back. However, really depending on the dose and the volume that's being treated, the area, it might be thinner than it was when starting, and that's just something that we as radiation oncologists need to be clear about, to patients as we're starting the treatment. Especially when you're treating in the chest, cough is pretty common because the airways are sensitive, and this also goes away. And finally, esophagitis. No matter what kind of treatment, if you're going through the esophagus, you're going to get some discomfort when swallowing. Also, something that is short term. It's important to know that we have treatment for this, and it's not to say that every therapy we have has a solution, but we have many different kinds of medicines for pain, for example, including topical therapies that are numbing, non-narcotic or non-opioid drugs, and obviously opioid drugs. So there's a lot of therapies we have for the discomfort. The skin reaction is very common, and we have a lot of different kinds of skin creams. Often the easy stuff is the best, Aquaphor or Vaseline, but there's a lot of different kinds of emollients and sort of solves that can be used for radiation therapy. And similarly, there's many approaches for mucositis. So again, there's numbing solutions with other pain medicines. There's really good evidence now for probiotics, just like a couple of tablets a day can really help with the mouth discomfort. And potentially most importantly, particularly at comprehensive cancer cancer centers like Simmons, we have a huge team, many of which patients meet before starting therapy. That includes dietitians and nurses and speech therapists and rehab experts, both physical therapists and cancer rehab doctors. There's music therapists. There's a huge group of people who are here and help work with patients over the course of their treatment to help minimize both the experience of and the side effects during therapy. In a long-term chronic perspective, there is some slightly different sort of portfolio of side effects. So there is often some degree of skin or soft tissue change, which for the vast majority of times is unnoticeable. You would notice it, a family member might notice it, but there is often some subtle change in the skin. Dry mouth when you're treating the head and neck, for whatever reason of treating the head and neck can be common. In 2025, actually, we're quite good at avoiding this as a very serious side effect, but it can happen, and is always a discussion with a radiation oncologist. Speech and swallowing difficulties, both with respect to treating the mouth or treating the chest, the esophagus for lung or esophagus cancers, can be quite frustrating. There's a big team, again, and a lot of therapies to improve it, but that's something to always discuss. And finally, there is some small risk, and again, this is small, of having some shortness of breath after radiation therapy. In terms of what we would consider the really serious side effects of radiation, one of them would be bone injury, such as a jaw injury after head and neck radiation in particular. But it's really uncommon, and frankly, I treat a lot of patients in the head and neck, and it's really uncommon to have very serious bone injury, fortunately, because of the technologies in our dental colleagues. Cardiovascular injury, as you heard from Dr. Rahimi, is something we have focused profoundly on to reduce the impact on, whether it's breast radiation or chest radiation for lung cancer, esophageal cancer. We do a lot to try to minimize the effect on the heart, but it's not zero, and this is one of the reasons why we pay attention to it clinically, and also we have our cardio oncology colleagues whenever there's any significant question. And finally, a very common question is what about second malignancies? Everyone hears that radiation can cause cancer. The reality, though, and I think this is a very important sort of concept to remember, is that absolute risk, in adults is really, really low. It's less than 1 in 1,000. It's actually often much less than 1 in 1,000 patients. And it's really important to remember that you first have to cure the cancer that is known. And so while we always pay homage to this, very serious complication, the absolute risk is really low, and it's much less problematic than the cancer that's in front of you on that given day. Hand it over to Dr. Rahimi to talk more about other parts of the body.
Perfect. So moving down the body, we'll talk about the breast, abdomen, and pelvis. Okay, great. So again, the acute side effects. So with breast, what I have highlighted here in green are kind of like the most common. And if it's not highlighted, it's not very common. But for the breast, redness, just kind of like a bad sunburn and fatigue is something we see very commonly. We can get swelling to the breast, sometimes blistering. If we're treating an extended lymph node field, we can get sore throat, which is usually just, a couple weeks, but will go away. And then it's pretty rare for us to get any inflammation to the lung or like a pneumonia from the radiation. As far as the abdomen and pelvis, when we talk about acute side effects, it's pretty common for people to get nausea, less common for them to get vomiting, but it can happen. Again, fatigue is something that we see with most radiation plans. If the bowels are in the field, people can get loose stools or diarrhea. And in the pelvis, if the bladder is in the field, you can have kind of increased urination or pain with urination. And if we're treating very large volume, like the entire pelvis, and a lot of the bone is in the radiation field, then we can get bone marrow suppression, which would lead to a drop in blood counts, which is, again, pretty rare. And we usually have to treat a large volume and higher doses for that. So as far as late side effects, with the breasts, the most common ones in green are shrinkage of the breast. It's pretty typical that you can get like a 5 to 10% shrinkage. Not something that you normally can tell with clothes on, but with clothes off, just usually a 5 to 10% change. Usually not even enough to be like a cup size. It's pretty common to get darkening of the skin. So you might just have like a shade or two darker. The average person wouldn't be able to tell, but your treatment team would be able to tell and usually see the radiation field. So women can normally still wear like a low cut shirt and still feel confident in that scenario. And then again, fatigue, usually the fatigue gets better within a month or two, but it sometimes in a small proportion of people, it can extend past 3 months. And then scarring and rib fracture, scarring of the lung or rib fracture is pretty rare. And it's also more rare to get fibrosis or thickening of the skin, but if it does happen, it's usually just a minor amount of fibrosis. For the abdomen and pelvis, again, darkening of the skin is the most common thing. That is usually minor that we can tell. And things that are very uncommon would be necrosis of the bowel, kidney or liver. Again, we have dose constraints that we practice under, and we review all of these as the physician is contouring all of this. And so we're very careful to try to stay below the dose that we know would cause this. But sometimes, it can happen even if we're within, even if we're within our dose constraints. It's rare, but it can happen. Rectal bleeding and then bleeding with urination, again, not so common. So in conclusion, before we get to the question session, we have many ways of minimizing our dose to important structures and monitoring that dose. And your doctors and your treatment team are going to do everything that they possibly can to make sure we're getting the highest dose to the tumor and the lowest dose to the surrounding tissue. We also have a very large volume of information and experiments that have been done over many decades that have allowed us to know kind of what dose constraints are for different parts of the body. And we usually try to stay within those dose constraints so we can deliver a safe plan of radiation. And your radiation oncologist will always weigh your risk benefit ratio when recommending radiation. And this will allow us to provide a treatment plan with the most benefit and the lowest toxicity. And so they're highly trained, and we do this all the time, and many people can get back to living a normal life after radiation. And so we want to make sure that the general public has a lot of these principles on the edge of their fingertips, so you can help friends or family members that may be going through this. And we would love to take any questions at this point that anybody has.
Thank you both. This has been fascinating, and I'm really, really excited to get into the questions. I've tried to organize them by pre-treatment, in-treatment, and post-treatment, and we'll see if that organization works. But the first question is, any recommendations for prehab or preparation advance for both the patient and the caregiver when radiation is the treatment plan?
Yeah, I'm happy to answer that. So the main thing is trying to come to the radiation department and be well fed. So if you're going to be doing a head and neck treatment, Dr. Sher can chime in on this, having good nutrition beforehand. I think for pelvis, that's probably very important as well. Making sure that you're not going out and sunbathing before radiation treatment, so you're not coming in with a sunburn and then we have to radiate a sunburned area. And then, just getting proper nutrition and rest. And for the most part, we'll walk you through the rest of it.
Yeah, I mean, I think that hits the really important parts of the pre-treatment sort of idea. Number one, though, is it really depends on what you're treating. So, if someone that has a head and neck cancer, then it's really important to work on the swallowing. And oftentimes we'll have, swallow consults with patients to learn how to, optimally swallow safely, or a dental evaluation if there's some question about, the dental structure. But from a patient and family standpoint, I think it's really important sort of to plan, meaning, hope for the best, but, uh, plan for, the worst, so to speak. Radiation is every day. You don't want to miss a day. Are you going to have people to bring you back and forth if you can't drive? Most of the time you can drive, actually, as the patient. And so coming up with people who, family and friends, to help, whether it's transportation or, to help with eating and food and sort of diet and things over the course of the therapy can be really helpful, and to deal with that up front and sort of have a plan as opposed to, sort of scrambling, when there's a problem.
So we've mentioned that radiation sometimes precedes surgery or treatment like chemotherapy or surgery, and sometimes follows. So the question was, can you explain how that's determined and provide a little more information there?
And I think, again, it depends on what we're treating. But so sometimes, for example, I can give the breast cancer example. Sometimes if it's like a later stage, then there's a higher chance. If it's in the lymph nodes, we want to try to give systemic treatments up front so that it doesn't spread to other parts of the body. Whereas chemo is more of a systemic treatment. The chemo, the biologics, immunotherapy are more systemic and treats everything in the body, versus the surgery and the radiation is more local and treats just that one area. So depending on the stage of disease, that could be one reason that chemo or one of these other agents is recommended up front. Another reason could be if it's early stage. However, the surgeon needs the radiation or the chemo, or usually the chemo, to shrink the tumor before surgery so that they can get adequate margins, and so that they can make sure and ensure that they are able to completely remove the tumor. And then there's a lot of new protocols that are constantly coming out and new clinical trials. And in some cases, in a lot of cases, some of these protocols and different chemotherapy regimens are being given upfront so that we can see the biologic response of the tumor. And the advantage of that is then the patient is taken to surgery. And if they still have a lot of tumor or there's a huge tumor burden, then it gives the medical oncologist an opportunity to talk about more systemic agents after surgery and radiation, because we know that the biology didn't react as well to those particular agents. So there's many different reasons, and it's gonna just depend on what we're treating and what the actual clinical scenario is. But I think those are the main reasons for doing it up front, the systemic therapy.
And in fact, every patient is different, and within any given disease, there can be many different ways of sequencing or doing radiation or surgery, or chemo first or radiation afterwards. And the most important piece is getting all of the information from the beginning. So you have multidisciplinary consultation. You meet your radiation oncologist, you meet your surgeon, your medical oncologist, kind of from the start, so you know the entire team, and that plan is laid out, so you understand where each of these different pieces fit together.
Thank you. I think we're going to have some similar answers to some of these questions and how patient dependent some of the answers are. But for a patient who has had radiation and then is found to have a reoccurrence of cancer, what radiation options might be available at that point?
Yeah, again, it's going to, oh, go ahead, Dr. Sher.
Oh, no, well, I was just going to say the first thing that's important there is to understand what is the treatment approach for that patient. Are you trying to cure the patient after a recurrence, or are you trying to, make a symptom better or palliate it? There's a very common question: can you irradiate something twice? We hear this all the time, and the short version is it depends, because tissue can only tolerate so much, and it depends on the previous dose. It depends on, whether this is new tissue or old tissue, and what the new sort of disease is. And so in the setting of a curative intent treatment, oftentimes, most of the time, we aim for surgery, actually, because that tissue's been irradiated. But sometimes even after that, the cancer is not all eradicated, and we do need to use radiation. And this is sort of true across the disease sites. But it really is a very complicated patient-specific sort of decision. But with today's technology, we can do more and more. And it really depends on what we're trying to accomplish with the reirradiation or in that, recurrent setting.
And very similar question. This was put in the reference of a prostate cancer diagnosis, but I have a feeling it applies to many diagnoses when a tumor is removed surgically and then a patient is sent to have radiation. What exactly is the target of the radiation if there's no tumor?
So it's typically, I mean, again, every situation is different, but it can be the surgical bed. So where the surgeon where they removed it, because sometimes with surgery, even though they remove the tumor, you can still have microscopic cells that are left behind. And that's kind of the job of the radiation, is to try to eradicate any of those microscopic cells that we can't detect on imaging. And so to try to ensure less chance of a recurrence. The other area that can commonly, be incorporated in that are like the regional lymph nodes is what we call it. So the nearby lymph nodes, which has like a higher propensity to have spread too. I can't hear you. Sorry.
You're muted. Yeah.
So sorry. The next question is about immunotherapy, which we know has been advancing options for patients. What is the intersection of immunotherapy and radiation? Is there one right now?
That's a very big question. I think to start, immunotherapy is a systemic treatment, meaning, it works everywhere. And so on some level, the relationship between immunotherapy and radiation treatment is very similar to how it is with chemotherapy and radiation therapy. With the main difference being typically we don't give them together, they're separated, either radiation first and then immunotherapy, or vice versa. So for example, in lung cancer, we'll often give chemoradiation and then immunotherapy, and the immunotherapy really makes a big difference. In other diseases, you give immunotherapy first, and then maybe you do surgery, or then maybe, you do the radiation therapy. Within the radiation sort of community, we also like to think of delivering usually stereotactic radiation, but sort of very high dose to enhance the effect of immunotherapy. And I would say this is largely experimental, although we do it sort of clinically to try to make the immunotherapy more potent. But I think there's one concern that immunotherapy or idea replaces radiation. We're excited to see how they work together to improve outcomes and to improve survival. And so it's actually really thrilling to be part of this because I do think actually they're going to work quite well together.
Okay, and the next question is kind of in the after post-treatment. How long would a patient be radioactive, quote unquote, after radiation treatment? How long does the radiation stay in the body?
So the radiation that is delivered typically by most of these treatments that we talked about, they're not radioactive once they leave. So even during treatment, a patient is not radioactive because the radiation is coming from a machine externally, and it's getting deposited into the body, but it's not, as soon as it hits the tissue, it does what it does, and the patient is not radioactive anymore. However, in saying that, there are side effects, and we talked about acute side effects and late side effects. And Dr. Sher had spoken about how, the cell kill and the cell repair doesn't happen immediately. It takes time for that to happen, and it can happen over months. So we can have an evolution of the side effects, and the late side effects can continue on from after 90 days to years. And so it can, we see side effects years after treatment. Now, the one caveat to all of this is, sometimes with something like thyroid cancer, they may prescribe, the nuclear medicine doctors may prescribe radioiodine pills, in which the patients are actually like swallowing radiation pills. And then in that scenario, they would be radioactive, and there would be some strict guidelines in how they would live their life for those next 3 to 4 days, because then you have to isolate. But just the standard radiation that you're coming in and getting the radiation from a machine, patients would not be radioactive.
The last question that I think we have time for is, can you speak to how artificial intelligence is informing radiation treatment?
So this is sort of a passion of mine, so I'll maybe start. Ultimately, artificial intelligence aims to replicate and then, be superior to what, we can do as physicians. And so I think to conceptualize how it's going to impact medicine or radiation in particular, number one is it helps us identify, faster sometimes, the targets, whether they're tumor targets or they're normal tissue structures. Artificial intelligence algorithms allow us to more quickly identify sort of these sort of parts of our job to, direct the radiation therapy. AI is also very good at making us deliver better plans, and it kind of gives us a head start into how we can optimize and lead to the best possible plan for patients. That's a human planner would take a little bit longer too. And the third piece is it's really helping us to identify prognosis. Is this patient going to have a better or less than expected prognosis for a given, say, CAT scan or blood test and so on? Honestly, this is mostly experimental, but as most things in technology, and especially with AI, it advances remarkably quickly. And so I think understanding that it's really an enhancement of our care, not a replacement of, is the best conceptualization of it. And I think every single year, if not faster, you're going to see some other use case for it. And ultimately, it's going to make us better doctors and most importantly, deliver better care for patients. Hopefully not replace us.
Wonderful. Thank you so much. Again, this was so informative. You will receive a copy, a recording next week for those who have registered for this. And you'll also continue to hear upcoming Lunch and Learns that will be happening throughout the year. Dr. Rahimi, Dr. Sher, thank you so much for joining us today.
Thank you guys so much. And thanks for everyone's attention over this hour.